We have another dynamic duo that's going to speak with us this afternoon about hearing and auditory type issues that are related to head and neck cancer. So to kick off our afternoon session is Dr. Lindsay Moore. Dr. Moore is a neuro-otologist. She's currently finishing her fellowship here at Stanford. She's been with us for about 3 years. But I heard yesterday that if you hadn't been an otologist, you would have been a head and neck surgeon. So she has a special love for us. So I'm really happy that you're here today to talk with us a little bit about some of the hearing and otology related issues that our patients deal with.
Good afternoon, everybody. Hi, I'm Lindsay. Nice to meet you all. Thank you so much for having me. I actually did my residency training at the University of Alabama in Birmingham, Alabama, and there's a massive volume of head and neck cancer there. So this is a subject that is near and dear to my heart, so I was really excited to get a chance to talk about some of the things that I think are sometimes not talked about very commonly for head and neck cancer patients. And that's because there's very important things to deal with related to the cancer, things from surgery, radiation, and chemotherapy. And I think sometimes the hearing is a big quality of life factor for patients that doesn't get talked about enough. And that's what I found in doing my research for this talk today, too. So hopefully you'll learn something. I'm going to, somebody stop me if I'm talking too much, but I'm happy to take questions at the end, of course, too. So disclosures, I don't have any. There are several products that I suggest just as examples here. I don't have any financial connections or ties to any of those things that would bias that information. And then I do just want to say that there are some sensitive photos, and I apologize for that for anybody who may be sensitive to those things. These are mostly either surgical videos or pictures of ear diseases that could be sensitive or uncomfortable for people. I'll try to give a warning about those, and I just want to let everyone know I didn't just include them because I'm a surgeon and to include surgery slides, but I really truly think sometimes they help patients better understand what's going on with them and to help illustrate and educate. So the goals for my talk today, first and foremost, of course, I want to educate and raise awareness about the otologic or ear-related issues that face head and neck cancer patients. Again, I think this is a topic that sometimes gets passed over, but really truly can affect a patient or your loved one's life significantly. I want to inspire and encourage you to seek care for your otologic issues. Again, head and neck cancer is a big deal, and there's a lot to deal with from the physicians managing this. And so sometimes it actually takes the patient or their loved one speaking up and saying, hey, I know we've talked about all these things, but I want to talk about some of the problems that are related to hearing or ears. And so I really want to encourage you to be your own advocate for your otologic health, because sometimes that's what it takes. And then I want to offer you hope that there are treatments that can really improve quality of life, and which is especially important when you're already having to deal with something like cancer. So what is otology? Otology is a fancy word meaning that we are ear doctors. So we study both normal and pathologic or problems related to the ear. But that includes a lot of things that I think people don't hear about or don't know about. Of course, it includes the ear, your external ear, which we call the auricle or pinna. But it also includes things like hearing, naturally, but your balance system as well. Eustachian tube function, which we're going to talk a little bit about because it's a big problem for a lot of cancer patients. Facial nerve function. Don't ask me why, but the nerve that controls the movement to your face runs right through your ear. So that can be an issue as well. And then, of course, diseases of the temporal bone, and that's kind of illustrated in this picture here, meaning this bone that you see on the side of the skull that has the ear, but it also goes all the way basically to the center of the brain, close to your brainstem. So we cover a fairly large range of things. So what types of head and neck cancer patients can have ear problems? And the answer is truly all head and neck cancer patients. This can be related to the cancer itself, or it can be a side effect of the treatment. And all three treatments can cause otologic issues: radiation, chemotherapy, and surgery. In particular, patients who have had radiation therapy, which is a large percentage of head and neck cancer patients. Patients who've had chemotherapy, again, a large percentage of patients. Some patients have hyperbaric oxygen therapy, and that can cause some issues. Of course, if you have a tumor of the ear or the temporal bone, those cancers that arise from there intrinsically are actually fairly rare. More commonly, when we have cancers that are involving this area, it's skin cancers. Everybody, please protect your ears with sunscreen. Or the parotid gland, which is the salivary gland in your cheek. Tumors of the nasopharynx and the oropharynx, in other words, the very back of the nose and the back of the throat, those can definitely cause a lot of problems. We'll talk more about that. And then even patients who have cancerous lymph nodes can have some otologic-related issues. And this picture here is just to illustrate the reason that any cancer of the head and neck can cause ear problems is because it's all connected. It's dense nerves that kind of cross-innervate and relate to everything. The anatomy is way more closely related than one might think, and so that's why this is hopefully pertinent to a large number of people. So Ear Anatomy 101, bear with me here. There will not be a quiz, don't worry, but I think that going over some of these, briefly just going over the anatomy will help make some of the issues that patients can have make sense. So when we're talking about your ear and sound, of course, we have your more recognizable external ear, the auricle or pinna. Here we have your ear canal. Can you see my cursor? Yes. Your ear canal that leads to this thin little membrane here, and this is your tympanic membrane or eardrum. That is connected to these three little bones. Oh, my cursor went away. These three little bones right here that are in a chain. This is the bones of hearing. And those are connected to your inner ear, which includes the cochlea right here. That's your hearing organ of your inner ear. And then these hula hoops here are your balance canals that deal with your balance system. And then the nerves that take both balance and hearing information to the brain and the brainstem that's illustrated right here. So when we talk about the ear, we divide it into three parts. So you have your external ear, basically everything on the outside of the eardrum, including the outside layer of the eardrum itself. This area is lined with skin, so it can be subject to squamous cell carcinoma or other types of carcinomas that arise from skin cancers. And then we have your middle ear, and this is an important one for some of the things we're going to talk about today. So your middle ear is actually the space that is on the other side of your eardrum here. It houses these three bones of hearing, or your ossicles, and it has this space that actually has this really important tube right here, your Eustachian tube. We'll talk more about that in a minute, but it drains fluid from this middle ear space behind the eardrum, actually out through the tube that ends in the back of the nose. And then your inner ear, we can see here, involves your cochlea as well as your balance canals. These are essentially fluid-filled tubes that are protected by some of the hardest bone in your body, as well as the nerves, and they deal with hearing and balance. Okay, that wasn't too bad, right? That was hopefully, okay, good. So what type of otologic issues can patients have who have head and neck cancer? So hearing loss. I will go ahead and have a disclaimer that I have a world-leading expert in the field of hearing loss following me, so I am not going to even attempt to touch too much on that, but we will talk a little bit about it. There are two types of hearing loss, a mechanical or what we call conductive hearing loss, or what we call sensorineural hearing loss that is more related to the nerves and sensory structures of the inner ear. Tinnitus, this is a big one. We'll talk about this very briefly, but this actually goes hand in hand with hearing loss. Fullness and pressure, that's a big one that head and neck cancer patients end up having to deal with. Some of the lingo that you may hear in the medical literature is aural fullness. Eustachian tube dysfunction is a really big one. We'll talk more about that. Pain, which we call otalgia, when it's related specifically to the ear, that's also a very common one. And then having chronic or recurrent fluid behind the eardrum, we call that a middle ear effusion. Chronic infections, both of the outer ear structures and of the middle ear, that fluid that builds up in that space. You can even have bone necrosis and infection of that temporal bone that can happen from radiation. And then, of course, there can be aesthetic or functional issues from losing part of the ear if a cancer is involving that. And as we talked about, facial nerve dysfunction or dysfunction of the facial movements based on that nerve running in proximity. So briefly, hearing loss. When we talk about hearing loss, there's two main types. We have it kind of anatomically divides right down the center. So we're looking here at your eardrum, the three bones of hearing, and this middle ear space. And that area is usually involved in mechanical hearing loss or the conductive type. And then we have the inner ear here with your cochlea and the balance system, which is the parts that are contributing to the nerve-related or sensorineural hearing loss. And so patients can have a mechanical hearing loss if the tumor is involving or blocking the ear. That makes sense. Surgery from several different types, including even the nose and mouth, can cause scarring that ends up causing a mechanical hearing loss. Radiation, we're going to talk about that, can definitely lead to fluid behind the eardrum, which causes a mechanical hearing loss. And then infections of that fluid or the middle ear space can cause a mechanical hearing loss. Treatments for this type of hearing loss, the mechanical type, are a little easier to deal with, at least from my perspective as a surgeon, because if you think about it like a car, if there's a part that isn't working, you can fix it. So sometimes there are surgical options for those things. But I do want to point out that often, and we'll talk about why, the answer for this conductive type of hearing loss can actually be a hearing aid rather than a surgery. And then we're talking about the nerve type hearing loss. This is a big one. And this is because there are a lot of the chemotherapy regimens that head and neck patients get on, particularly cisplatin or platinum-based chemotherapy regimens, are actually ototoxic, or they damage the sensory system of the nerves within the cochlea and can cause hearing loss. That happens in everywhere from 30 to 80% of patients who end up with that particular type of chemotherapy regimen. Radiation can cause actual damage to the cochlea as well, so it can cause not only a conductive hearing loss, but a sensorineural one. That can happen in anywhere from 10 to 90% of patients. I know that's not a helpful statistic, but that's reflective of how little literature there is out on here. Suffice it to say that most patients end up with some amount of hearing loss that end up having radiation that the fields involve the inner ear. It's dependent on the dose for both chemotherapy and radiation, the degree of hearing loss and whether or not it's present. And then the combination of certain types of chemotherapy and certain types of radiation can have an additive effect for the hearing loss. I will say that there are efforts going on in both fields, the radiation field and chemotherapy fields, that are trying to correct this problem. So that's some good news. But I want to emphasize that the treatment for this type of hearing loss is a hearing aid. We currently don't have a lot of surgery or any surgery at all that can fix the nerve damage and cochlear damage type of hearing loss. Suffice save that for one surgery, and that's only if the hearing loss is very, very severe, and that's a cochlear implant, which is basically a superpowered implantable hearing aid. So hearing loss is actually the most common otologic issue in head and neck cancer patients. Again, the statistics are all over the place, but it ends up being most patients. And it's important to know that this can happen immediately or during treatment, or it can be delayed, happening years after treatment. In some cases, it can be reversible, particularly if this is a conductive hearing loss, often treating the reason behind the mechanical hearing loss, we can fix that. Or it can be irreversible, which is more common with the nerve-related hearing type, where we can't get back those cells within the cochlea or the nerves themselves that get damaged. So what are some symptoms that are associated with hearing loss? And I wanted to talk about this because it's a very important thing that I talk about a lot to my patients in clinic. Tinnitus is a really bothersome problem. That's ringing or sounds that are within the ear that aren't actually happening outside of the body. And it's really important to know that tinnitus is actually a product of the hearing loss. This is a very oversimplified version, and Dr. Fitzgerald can comment more on this, but essentially, tinnitus is an internal noise created by your brain because of the loss of hearing. Your brain is used to receiving information about a certain frequency or pitch of hearing, and when that goes away, your brain creates a noise that isn't actually there as a way of sort of coping with that. So that will be important in a moment, but suffice it to say, if the tinnitus is from hearing loss, to help the tinnitus, help the hearing loss. Fullness and pressure sensation, that's a big one that can really bother patients. Pain and sensitivity to sound, which we call hyperacusis. And then you can have an echoing of your own voice or an amplification of other internal sounds, which we call autophony, and that can happen from fluid behind the ear. And I just wanted to call attention to this paper that had a quote that really hits home the impact that hearing loss can have on patients. And it says, individuals with untreated hearing losses were more sorrowful, with more feelings of loneliness, depression, worry, anxiety, and paranoia. They had fewer social activities and were less able to integrate information regarding their environment. Hearing loss affects individuals' psychological situation and, if untreated, contributes to social isolation, depression, and low self-esteem. It also seems to be a cofactor related to senile dementia. So hearing loss is more than just not being able to hear what's going on around you. It has widespread effects that go very deep and really affect quality of life. So my last little thing here on hearing is I have two major points I want to make. The first one is check your hearing and protect your hearing. So again, be your own advocate for your health. If this isn't already done, encourage your ENT or your oncologist to arrange a hearing test, which we call an audiogram, before you have any type of treatment that could affect your hearing, including certain types of chemotherapy, certain types of radiation, and surgery in certain areas. Then check your hearing during and after treatment, and then every 1 to 5 years after that, or anytime you or a loved one notice a change in your hearing. So we want you to frequently check on your hearing. And then importantly, often this can be bilateral, but especially in the case either way, and especially if you have one good ear, you really want to protect the hearing you have left. So that means wearing FDA-approved hearing protection or avoiding sounds above a certain sound level that could cause damage to the ears. And the type of noise exposure damage to hearing often doesn't show up right away. This happens later on. And this chart here just shows that above around 70 decibels, you start to have damage that is caused to the cells, causing a sensorineural hearing loss. You can see here the things, yard work, lawnmowers and things can cause it. Certain occupational machinery that people work with. Just be aware of the things that are around you that are causing excessive noise and protect your hearing, because when it starts to go, it can become an increasingly bad problem. And my other final thing I want to say is please treat your hearing loss. It really affects your quality of life, sometimes more than people actually are able to appreciate. It can be a safety issue. So driving with poor hearing is dangerous. Not being able to hear safety alarms like a fire alarm or something is dangerous. And then needing to hear a loved one, if you have, grandchildren or children crying out in help, or a loved one who is fragile or ill and needing help, it's a safety issue. And lastly, as we touched on, it's associated with cognitive decline and cognitive mental load. So hearing loss has been tied to cognitive decline and brain atrophy, and it has also been tied to shown that there is a mental effort that listening takes. When you have good hearing, your brain doesn't have to work that hard to hear. When you have hearing loss, your brain is working much harder to do a task that it used to do without thinking. And that can lead people to feel exhausted, drained at the end of the day from straining and having to use their brain hard, thinking hard to try to hear. So please, please, please treat your hearing loss. Dr. Fitzgerald is going to tell you all about how you can do that with hearing aids. The stigma of hearing aids is going away. With the new Bluetooth things, everybody, ages 15 and up has some kind of device in their ear. So don't worry about it. Treat your hearing. You'll thank me later, hopefully. And lastly, taking charge of your otologic health. So there's a lot of app-based products that you can do that can help you with your otologic health. I don't know what the policy is on pictures, but if you want to snap a picture with your cell phone, please feel free to do so. We won't go through all these apps, but suffice it to say, there are apps now where you can do a hearing test on yourself at home. My disclaimer is that this hearing test is not going to be equivalent to a hearing test that an audiologist gives you, but it can be a good indicator that you need to go see an audiologist to get a hearing test, and it can be helpful to the audiologist to actually have that information. This is also another good way for you to be able to monitor and check your hearing through treatment and figure out if there's a hearing loss going on that you need to consult with your ENT or your audiologist about. There are several here. I personally use the Mimi hearing test. I don't have tons of experience with the other ones, but I feel like it's pretty good. It's been very helpful with my patients. There are decibel meter apps, or in other words, apps that can help you measure how loud a sound is. You may not realize how loud a sound it could be that could be damaging your remaining hearing. So there are apps where you can pull it out and it will actually tell you how loud the sound is and whether or not it's a dangerous level. There are actually some apps that can kind of help with hearing, that they sort of amplify the sound around you. So not a hearing aid, but sort of a hearing amplification helper. And then there are transcription apps for patients who have hearing loss that can help you have live transcribe if someone's having a conversation with you and put what's being said into words so that you can read it. And then tinnitus maskers or apps that can help with the tinnitus. Again, we'll talk about how hearing aids is the best for that. But there are also lots of different types of apps that can help deal with that noise, which tends to be particularly bothersome at night. So Eustachian tube, this is that tube we talked about that goes from the middle ear and drains out through the back of the nose. When it's functioning normally, it opens every time you swallow or yawn, and it acts as a pressure equalizing valve for the middle ear. It also drains mucus produced by the lining of the ear, which is not unlike the lining of the nose. And so that can drain out through this tube into the nose. A little bit of this one's not too bad, but there are some pictures of some ears here if anyone's bothered. So what is Eustachian tube dysfunction? It's blockage of this tube. And when that happens, it isolates that middle ear space from being able to be around the environment, which is not good when you're talking about a pressure system. So the lining of the middle ear will then absorb trapped air. This creates negative pressure system, and it can pull on the eardrum. Your eardrum is a really thin, pliable thing, much like plastic wrap. And when it gets pulled, it has tons of nerves. It's incredibly sensitive. So that tugging from the negative pressure can create pain, certainly like people have maybe experienced on an airplane, as well as a mechanical hearing loss. If that tube continues to stay blocked, you can have accumulation of the fluid. And this is a picture here of what we call serous otitis media, or fluid. You can see that amber-colored fluid behind the eardrum. That causes a conductive hearing loss as well as a pressure sensation. In this situation, this fluid is sterile relatively, but if bacteria contaminate that fluid, you then get a situation where you have a middle ear infection, which we call acute otitis media, which again can cause more pain, more hearing loss, and could cause rupturing or a hole to be created in the eardrum with drainage out of the ear, which is certainly not fun to deal with, more hearing loss, and then sometimes a surgery is needed to close this hole. So eustachian tube dysfunction in head and neck cancer patients, I think this quote here says it best. This is a well-known but poorly documented problem with head and neck cancer patients. And that's because, as we discussed, people aren't always bringing up the problems that they're having with ear, thinking, well, I need to focus on my cancer recurrence or other things. But and so there's not a lot of good literature for numbers for me to tell you. But you can have eustachian tube dysfunction either from physical blockage of your eustachian tube, like by tumor, for example, the nasopharynx to the back of the throat. That's actually most patients that have nasopharyngeal cancer actually have that because of the blockage, and that's often how this tumor is detected. And this can sometimes improve with treatment. And then the big one here is radiation-induced eustachian tube dysfunction. The literature says anywhere from 20 to 88% of patients who have radiation for any head and neck cancer end up with eustachian tube dysfunction. I'd say it's probably on the higher end of that spectrum. It can happen for several reasons. Inflammation is caused by radiation that causes swelling of that tube in the middle ear. This is an earlier reason that you can have it. And then it also changes the blood vessels and the sort of makeup of the lining of the inner ear that results in pressure and changes that trap that fluid. And then radiation in more longer term can cause scarring and fibrosis that inhibits the proper drainage of that fluid. So a lot of talk about this very uncomfortable problem. What can we do about it? So if you're having the middle ear infections, antibiotics is the answer, either by mouth if there's no hole in the eardrum or ear drops. For the fluid behind the ear, this is a little tricky. Obviously, the way to get that out would be to treat the eustachian tube dysfunction, which we'll talk about in a minute. But I want to make a really important point here. Ear tubes is one way we commonly treat eustachian tube dysfunction. Unfortunately, that is a very bad idea in patients who have eustachian tube dysfunction from radiation. The changes that happen to the ear and the lining of the ear, if a patient who has this type of eustachian tube dysfunction gets an ear tube, it's a setup for a lifelong problem of chronic drainage coming out of the ear and infections. So I have definitely seen ENTs that put an ear tube in, it relieves the pressure, it's great, the patients are happy, but then they're set up for a really bad problem of constant drainage that can lead to really serious infections. So it is the specialists who do just ears do not recommend an ear tube for this. An alternative that's also not great, but is certainly better, is a myringotomy, which is just a small cut in the eardrum and then suctioning out of that fluid. It's a temporizing solution. But when you have a cut that's made without putting a tube in it, that cut usually heals, although there is a risk that it doesn't heal up and could require a surgery. And then the eustachian tube dysfunction, which is at the heart of all of this. Good news is that many of these problems will get better around 6 months or so or after treatment when some of that inflammation goes down. There are ventilation exercises you can do, which is essentially exercises and things that can help you pop your ears or reestablish that opening of that tube. I have a couple of products down here, the Otovent balloon, which is like a balloon you squeeze and it pushes air through the nose back up that tube. And here's one by NeilMed. There's not a lot of data to support these, but enough that some patients find relief from it and they continue to be available. They're pretty low risk, so that's certainly an option. And then there's a thought that if this is done early and frequently during treatment, this may prevent some of these issues that can lead to lifelong eustachian tube dysfunction. And then lastly, there's a procedure called eustachian balloon dilation. It's an operation, a very minor one, but it's a procedure, and it's a possible option as kind of a last-ditch effort. And it really does depend, though, for certain patients, whether or not this will be helpful. Briefly, this is what it looks like. Here's this tube draining the middle ear to the back of the nose. Go through the nose with the balloon, insert the tip into the eustachian tube, and then inflate it, and that can keep the eustachian tube open and allow the fluid to drain out. The issue is that this can lead to the eustachian tube remaining too open, which is another problem entirely. Won't get into it today, but Dr. Jennifer Lee is our eustachian tube dysfunction expert here at Stanford, and I highly encourage anyone who has this issue to get a recommendation to see her because she can help guide patients on what would be the best way to treat this. Another sensitive content, I'm an animal lover. So chronic ear infections. So you can have chronic ear infections from the external ear or the ear canal. We talked about infections in the middle ear space, but radiation can cause changes to the skin around the ear and involving the ear, the auricle, or the pinna that can cause really bad infections. These can cause symptoms such as drainage, itchiness, redness, swelling, pain, decreased hearing, and then feelings of fullness. So how do we treat this? Sometimes patients who have had radiation need a little bit of help cleaning their ear. Your ear naturally cleans itself. But in these patients, you may need someone to clean out your wax for you anywhere from 6 months to a year. You may need ear drops if you get one of these infections. And then I will say, if you have an ear infection, actually anyone in general, please do not use Q-tips. Please, please, please do not use Q-tips. They only make things worse, I promise. Another little sensitive content here. Briefly, we'll just touch on this because I think I'm running out of time. If you have an infection of the ear that goes untreated, particularly in patients who have had radiation, you can end up with a very serious problem called osteoradionecrosis. This is when there's been a death of the bone surrounding the area from the radiation, changing the vessels and cutting off the blood supply. And then if bacteria get involved in that, there's actually an infection deep in the bone. And this can be a life-threatening. Unfortunately, I've had several patients actually pass away from this. This is a major problem. I want to reassure you, it is very, very rare. But my reason for, their treatment for it is weeks of IV antibiotics or a very extensive surgery that nobody wants to deal with. My point for bringing it up today and for showing you this disturbing picture is because I want you to please not ignore symptoms. In most cases that we see patients that it gets this bad, they've had chronic drainage or pain in their ear that they have not had evaluated. And this is much, much easier to treat early on than when it becomes advanced. So if you are telling your physician that you have pain or drainage and things aren't getting better, please advocate for yourself and see a specialist. Quickly go through the rest of it here. Otalgia or ear pain, we talked about many of the reasons that can be caused related to Eustachian tube dysfunction. It can also be a nerve-related issue. As you can see in the picture here, the nerves that innervate your ear come from all over the place. And so even if you have a cancer in of your larynx or the back of your throat, some of these nerves that innervate those things also innervate your ear, and you can end up with referred pain to the ear from other issues, even that are not in proximity to the ear. That can be from surgery. Actually, TMJ is a really common thing that can happen in anyone, much less head and neck cancer patients, depending on the tumor site. And TMJ is often felt as an ear pain. And then radiation can cause changes that are very uncomfortable. The good news is that most of the pain improves after 6 months of treatment when inflammation goes down. So that's good. Obviously, addressing those issues we just talked about can help improve pain. And then long-term pain that happens from scarring or nerve damage can sometimes be improved with physical therapy and massage therapy. So I encourage people to ask about that and get referrals for that. And then if refractory nothing else is working, we have pain specialists, usually anesthesiologists, who can help medically manage that. Just briefly, the facial nerve, it runs through the ear. It's the craziest thing I know. But some patients can end up with facial nerve issues because of damage either by the tumor or by treatment from their facial nerve. That can have a whole host, in addition to being aesthetically disturbing, that can have a whole host of other issues, including not being able to close your eye and causing eye damage to your eye, not being able to use your mouth properly to drink and retain water in the mouth. And so I just want to give a brief shout out to anybody who has facial nerve dysfunction that there are things we can do about it. Dr. Jean-Paul Pepper is an ENT who specializes in facial plastics, and he subspecializes in treating facial nerve issues. As you can see down here, there's some, in the middle column, we see there's lots of different surgeries that can be done with some pretty impressive results, as you can see from one of my patients down here in the very bottom column. So seek help if you have a facial nerve issue. Don't just think this is what I have to live with. There are many things that can be done, ranging from Botox just all the way to pretty complex surgeries that can be pretty impressive. And then lastly, just briefly, we talked about cancer that involves the ear. The temporal bone is much more rare. So I've been talking about things that are more broadly applicable. But if you do have a cancer of the ear or the temporal bone, it can involve, as we can see here on the left, it can involve surgeries that involve any degree of drilling out a lot of these structures, sometimes including the cochlea. And you can see here a couple pictures. I don't think these are terrible, but again, if you're bothered, please look away. This is a patient who had a squamous cell carcinoma that started as a sun exposure-related cancer that was on the back of the ear, where there often can be skin cancers that go undetected. And so he ended up having a large resection and then had a free flap or tissue transferred from another part of the body, in this case his leg, up here to cover this. And This may look grotesque, but this is actually a really beautiful, nice result. But as you can see, he doesn't have an ear anymore. He doesn't have an auricle anymore. So 2 things I want to comment on that. There's a great option for hearing, getting your hearing back for patients. Obviously, if you don't have this part of your ear, you're not getting sound in. So we have bone implanted hearing aids that work great to get sound to the cochlea when this is the situation. And you can see it's that small pin here that a sort of external device attaches to. It's covered up here. And then I think this is pretty amazing. Another thing that we can do, and patients often have to advocate for sometimes themselves, is the prostheses, the prosthetics that are available today for people who don't have an ear are incredible. You can see when being hand painted here, looks amazing. We install these brackets here, and then the prosthetic just clips onto these. You can also see he has one of those bone integrated hearing aids here. And as my last slide, you can see here he is with his prosthetic. And I will say that this is before it was painted to match his skin. He even has a couple different options for depending on how tanned or sunburned he is as well. So lots of available options. You can't tell here because I had to block his eyes, but he was very happy with this outcome. So there are things that can be done, and I just want to encourage you and give you hope that for whatever your otologic issues are, please ask about it, please get help, and please know that there are treatments. And thank you very much. I think I went a little over. I apologize, but hopefully that was helpful. So